I'm going to talk on balloon tamponade, uterine packing. What is the current status? So the principles of tamponade are that there occurs exertion of counter pressure on the uterine cavity, which reduces capillary and venous bleeding from the endometrium. In fact, it is an opportunity, a window of opportunity to allow correction of coagulation and coagulopathy and replacement of blood products. And we know that golden hour is very important, the time is very important, and we have to act at the correct time to diagnose atonic PPH and do some interventions to prevent morbidity and mortality. So balloon catheters are the most commonly used ones, and they are the Bakri balloon, the Sengston Blackmore esophageal catheter, our own Foley's catheter, condom catheter, which we can make and use it as an emergency. So this is a Sengston Blackmore esophageal catheter, which has been inflated inside the uterus. The most commonly used is a Bakri balloon, which is FDA approved. It is 100% silicone. Ductile shape allows to conform to uterine anatomy and shape, and it allows for hemostatic cushion application and limits clot adhesion. The large diameter lumen in the shaft and multi-ported non-abrasive tip allows for constant drainage, so uterine bleeding does not go undetected. But the only problem is the cost. This is which we can make locally. We can use 2 condoms. We can use a drip set, putting it inside and tying it firmly and instill normal saline. We can use a Foley's catheter, and outside to collect the blood loss, we can put in a Nelaton's catheter, or we can put 2 Nelaton catheter, one inside and one outside. So advantages are that it is a conservative method for management of PPH, easily administered and removed, and even the patient can be transported to higher center. The most important thing we should remember is the tamponade test. That is, once we put this tamponade and the patient stops bleeding, that means it is positive. But if it fails, we have to go for alternative methods. We can combine it with uterine compression sutures, which is known as uterine sandwich technique. And definitely we can avoid hysterectomy if we are able to provide a positive tamponade test. Contraindications are arterial bleeding requiring surgical exploration or angiographic embolization. If the uterine atony is persisting, if a patient is multigravida, we should not waste time in putting these things. We can directly go for hysterectomy. If there is any infection of vagina, cervix, uterus, or uterine anomaly, or if the patient is at DIC. Following vaginal delivery, we have to be sure that the uterus is empty of any placental fragments. We can use ultrasound or clinical examination to determine the uterine volume. We can insert the balloon past the cervical canal. A proper placement is important so that no dead space is left for the blood to collect. We can pack the vagina and we can instill 200 to 600 ml of saline or sterile water. Following cesarean delivery, we can put this tamponade via the incision and close the incision, avoid puncturing the balloon, pack the vagina, inflate the balloon, and connect to urobag to measure the blood loss. This is a small simulation of Bakri balloon where it is inserted through the vagina. We can insert it through the uterine incision during cesarean section. The balloon is inflated with normal saline and exerts pressure on the walls of the uterus. And then we can deflate it. So maximally we can put it for 24 hours. However, 4 to 6 hours time may be sufficient for achieving hemostasis along with other resuscitative measures simultaneously. Any signs of deterioration or patient is not improving should indicate more aggressive treatment. The device is not a substitute for surgical management and fluid resuscitation for life-threatening hemorrhage. It may be removed earlier if more aggressive treatment is required. We have to remove the pack and deflate the syringe. These are the various studies starting from 1993 to 2006 and different case series of patients using various methods. And we find that the efficacy is around, in cases maybe around 100% also. Coming to uterine packing, it is an alternative to further surgical intervention in patients with intractable obstetric hemorrhage. It should be considered when conventional therapy fails to provide any relief. What we need was 8 to 10 meters. We need a sponge holder with which we go to the fundus and start packing from above downwards. We should also pack the vagina to give additional pressure to the uterine packing. Antibiotics may be removed after 12 to 24 hours. It is simple and quick procedure. So whatever method we use, we should know that it is a temporary method, and hemostasis is what we are aiming at. If we are not able to do it, we should stop it, and concomitantly we should use the monitoring for signs of arterial bleeding, atony, and DIC. So to conclude, I would say that Tamponade is one of the choices for management of atonic PPH with 80 to 100% efficacy. Tamponade test can be considered positive if patient shows positive response to PPH. Further surgical interventions can be avoided. Other resuscitative measures should continue simultaneously. Packing also needs consideration if other methods fail under antibiotic coverage. Thank you. Thank you once again.